Is manipulation more effective than medication or placebo for acute low back pain? A recent study published in 2013 in the journal Spine has gained some notoriety. News headlines are quite encouraging, implying that manipulation for acute low back pain is better than medication. As always, it's tempting to simply quote and support this simplified summary, but as usual, there's a bit more to the study than the headline. Let's review this interesting study to see what conclusions we might be able to draw and what its findings and study design may imply for the future. It's always important to recognize the importance of dealing with acute low back pain as quickly as possible, given that in industrialized countries, the direct costs are estimated to cover only 15% of the total expenditure. The indirect costs, which include lost work time, long-term disability, and early retirement, account for the vast majority of final costs. This study was conducted in Germany. In Germany, low back pain is the major cause of work disability and is third as a reason for early retirement. The title of the study is Spinal High-Velocity Low-Amplitude Manipulation in Acute Nonspecific Low Back Pain, a double-blinded randomized controlled trial in comparison with diclofenac and placebo. It's important to note that chiropractic is not regulated in Germany, and as a result, anyone can perform manipulation. This study involves medical physicians who have been trained in a form of manipulation more similar to osteopathic manipulation than chiropractic. We'll discuss this further when we review the manipulative technique used in this study. This study utilized 5 orthopedic or general practice physicians in 4 different cities who selected the patients who were contacted for inclusion in the study. These physicians are also the ones who performed the treatment. 4 additional physicians acted as blinded investigators. Inclusion criteria were that patients were of either sex between 18 and 55 years of age. They had acute low back pain of less than 48 hours prior to randomization, and of course, they gave their written informed consent. Exclusion criteria were fairly standard, but also included intolerance to NSAIDs or paracetamol, an occurrence of low back pain or spinal manipulation for any cause within the last 3 months, known or suspected abuse of alcohol or drugs, any metabolic, malignant, or any serious organic or neurological disease, atopic diathesis, or any structural disorders of the spine. Patients were initially randomized into 3 study arms or treatment groups: spinal manipulation plus a placebo drug, sham manipulation plus diclofenac and NSAID, or sham manipulation plus a placebo drug. This last group was the control group, given that neither the manipulation nor the medication were true. Eventually, the placebo group was closed for ethical and practical issues due to lack of effect, with many patients worsening. This then began phase 2, when subjects were randomized to one of the 2 active treatment groups. The statistical results were based on the direct comparison of only the 2 active treatment groups. Outcome measures used included a self-rated physical disability score using a Roland-Morris Disability Questionnaire, a 100mm visual analog scale, function using the SF-12, time off work, and the number of days taking the rescue medication paracetamol between baseline and 12 weeks after randomization. It's important to note that outcomes were assessed by a physician different than the one who performed the treatment, and they were blinded to the treatment allocation. It's also important to note that in the final analysis, this physician subjectively rated whether patients had full or partial resolution of their pain. One curious potential weakness was that all subjects were given paracetamol, 500 milligram tablets, to be taken whenever needed, up to 6 tablets per day, a so-called rescue medication taken when patients felt they needed relief. The question is, although differences between groups are not affected by this medication inclusion, was the degree of success of both treatment approaches affected? What this means is that the improvement of either group may partially be based on the use of this medication. The most important question is, if these are German medical doctors performing the manipulation, what technique did they use? The researchers state that they utilized the, quote, most popular segmental technique in Germany for the lumbar spine, almost identical to osteopathic high-velocity, low-amplitude manipulation, unquote. So what constituted HVLA? The real manipulation was performed with the patient's side lying with the lesion side up. The patient's leg was flexed until space between the involved segments opened up. Rotational forces were applied in opposite directions both at the shoulder and lumbar spine. In essence, a spinous pull move was applied. The sham manipulation was designed to treat the SI joint by traction on the leg combined with a cephalad impulse on the sacrum, and was performed on the opposite side of involvement. Both of these approaches were an attempt to not affect the involved side or segments. The results? Well, improvements in the visual analog scale were that although both groups had a mean of about 55 on a 100 millimeter pain scale at baseline, both groups improved differently in their VAS scores. At 5 days, the mean for the diclofenac group was still about 40, with the mean of the SMT group at about 20. At 9 days, the mean for the diclofenac group was about 30, with the mean of the SMT group at about 15. For the mean difference in the Rowland-Morris scores between groups, it was significant at about 3, with a mean reduction in Rowland-Morris scores of about 7.71 in the spinal manipulation group and only 4.75 in the diclofenac group. We can see here the number of patients responding after 3 days that they had either complete relief or improved. For spinal manipulation, this totaled 30. For the diclofenac group, this totaled only 20. And here is the response after 9 days. For spinal manipulation, 29 patients reported complete relief or improved versus only 21 patients in the diclofenac group. Not statistically different differences were that although the amount of medication taken was higher in the NSAID group, it was not statistically significant. And although the length of time that patients in the NSAID group took medication was longer, it was not statistically significant. The time off work was different between the groups, but again, not statistically significant. So what's to be gained from this study? There are strengths in this study, and the researchers should be applauded for conducting this unique study design. What is unique is that the sham manipulation was probably believable by the patients, and the use of a placebo in both the real and sham group allowed some comparison to a real effect compared to what might be considered natural history. Based on that assumption, it appeared that those on a true placebo management plan, the control group, did poorly, poor enough that this treatment arm was closed. Said another way, doing nothing or faking doing something did not seem to work for these patients. Limitations? This was a relatively small study so that the strength of the conclusions is statistically weakened. Given it was conducted in Germany and by German physicians, extrapolations to chiropractic patients in the U.S. is limited, although the manipulation is similar to a spinous pull move. As a whole, this study demonstrated that pain and disability for participants treated with manipulation was half that of a group treated with standard pain medication. Pain and disability improved faster in the manipulation group. Given this was only a short-term follow-up study, it would be important to conduct both a larger study, but also one that follows patients over years to determine recurrences, disability, and total costs. Regardless, one of the most important patient and employer-centered goals is early return to work, which this study seems to indicate is achievable with little risk or added cost using manipulation. So although a small study, it can be added to a growing list of publications that support manipulation over usual medical care for acute low back pain. The elephant in the room, though, is if medical doctors adopt this approach and learn and apply manipulation to acute low back pain patients, what effect will this have on the chiropractic patient population? Certainly in Germany, where chiropractic is not regulated, it's likely to become more common. In the U.S., both physical therapists and MDs might evolve into a significant economic competitor without the historical philosophical baggage associated with chiropractic. This might eventually prove a serious threat and should be considered in light of this study.